All right, Dr. Offutt, we are live. It looks like everyone is jumping in from the waiting room there. So I'm going to go ahead and just thank everyone for showing up tonight. And thanks for your interest in Vibrant, your interest in tick-borne diseases. I know that this is such a hot topic as we face, a national or really a worldwide pandemic. People are starting to look at what are some of the things that can make people sick outside of COVID-19, or that can complicate that, as well as this is becoming a large ticket item for the medical community as more and more people recognize the impact that vector-borne diseases have on human health, as well as chronic wellness or chronic illness. So I'm going to introduce Dr. Amy Offutt really quick here, and then she's going to take it away. I'm really excited for this chat tonight because she's got some great, she's got a great case study to go over and some really awesome information to share. Dr. Offutt is a director on the iLabs board. She's a medical director and co-owner of Heart and Soul Integrative Health and Yoga, located in Marble Falls, Texas. She completed her undergraduate studies at Abilene Christian University Medical School at the University of Texas Health Sciences Center, in San Antonio, and a residency in family medicine at Christus Health. She also has a master's degree in integrative medicine from George Washington University, and she's completed a fellowship in integrative medicine. So her calling to look for the cause of disease, in addition to how to manage symptoms, led her to her appointment by Governor Greg Abbott of Texas to the Pediatric Acute Onset Neuropsychiatric Syndrome Advisory Council in the summer of 2019. So Dr. Offutt, I just want to thank you for being with us tonight, giving us your time, your experience, your expertise. And I'm going to go ahead and pass it off to you, and you can take it away.
Thank you, Sarah. Thanks to everyone for spending your time to show up and listen in, and I hope that you have some good takeaways. As Sarah mentioned, I am an iLabs member, and the protocols and recommendations that I'm going to talk about tonight are my own, but I'm proud to be a member of the International Lyme and Associated Diseases Society. And if any of you are interested in plunging in and learning more, we have a lot of great educational offerings. I would encourage you to explore that a little bit more if you enjoy this presentation. First thing I'm going to talk about is Vibrant technology. I've been using Vibrant Labs now for a little over a year. I first learned of them from a colleague who had referred a couple of patients to me, and I noticed that just the detail and the amount of data that was on a report that she sent. So I called and talked to her, and she's the one that referred me, a doctor colleague referred me to Vibrant Wellness or Vibrant America Labs. And what I've learned since then is they are a cutting edge lab that highly values modern testing, efficiency, rapid turnaround times, clinician support, and just staying on the cutting edge of these tests that are so helpful to me as a clinician trying to take care of patients in my office. They can do high volume testing. Their turnaround time is about a week, which is great. You can see here they can test multiple types of samples, and they have a wide variety of different tests that they offer. The immunochip is what makes possible some of the efficiency and the excellency of this test. It uses a silicone chip along with some manufactured antigens to detect a small, sometimes otherwise undetectable sample positives that we might miss in other testing. As most of you know, one of the most challenging things in testing someone who's got a chronic inflammatory disease is getting a positive or a negative that you can rely on. Their technology takes away some of the issues that have to do with using gel matrix. They can test multiple antigens at one time in the same well. That really saves on time and also results in a less expensive test, which is great for the patient. They are able to add more antigen sets as more pathogens appear in the literature and more testing becomes desired by clinicians. And they're highly reproducible because they're completely automated. This talks a little more about the antibody detection technique that they use and having an enhanced IgM capability that helps more in the early detection of these diseases. They also use a multiplex PCR on a chip, which lets them amplify this basically a much greater increase in amplification for PCR testing compared to some of the traditional PCR tests. This lets us detect the organism in a much smaller amount, which helps us detect it earlier, or for instance, in a patient for whom it's not very present, but still there's been exposure, or maybe it's present in small amounts. They also use a technique called bead beating, which is helps to extract the DNA. It removes some of the contaminants that can be in the sample that might get in the way in more traditional techniques that get in the way of being able to access the DNA in order to run the PCR test. So just today, they published this article in Nature. It's in the scientific report section that talks about these microarrays, the high throughput single tier serological detection for Lyme disease. And for those of you who are really interested in the nitty gritty details of how these tests work, and even how the testing equipment was created, designed, and is utilized, this is a great resource, and it's an open paper, so anyone can go and read it. So they use 3 antigen types in their testing: the whole cell sonicate, which comes from a cultured organism. They use recombinant antigens and also peptide antigens. And this slide just depicts that. Test products, as we all know, those of us who order tests, we know that when we order a Western blot or an ELISA test, these have been used for a long time. This is just a reminder of what some of the tests are that are commonly offered that we're trying to use and have been using in the past. And these same technologies are still utilized. I think I would just describe Vibrant's technique as even more modernized and automated. So the takeaways from this, they can multiplex a large number of tick-borne infections. They can use multiple antigen types. It's cost effective because of the design of the technology, and the technology results in a higher sensitivity and specificity, which helps us be better diagnosticians from a laboratory standpoint. This is the panel called a tick-borne 2.0. And there, as you'll see, there are 4 columns. These can be separately ordered as a panel, or the whole panel can be ordered together, and that would be called the Tick-borne 2.0. You'll notice in the left column several different genuses of Borrelia, and then co-infections 1 is going to include some of the more common co-infections such as Babesia, Bartonella, Anaplasma, Ehrlichia. And you can see there's some unique speciations included in that test. The co-infections 2 are some of the other co-infections that we see that are definitely clinically problematic. And then opportunistic infections is the 4th column. And you can see there's several viruses included, which that's helpful. This is a sample report. I like their reports a lot. I've been looking at them with patients for a while. It's very nice and clear, both to me and to the patient, as to what they're looking at. You can see here they do have, like this particular sample, an IgG result, a current result, and a previous result, which makes it nice to see. I would say, especially even on the PCR part, where your previous result shows detected and it's still detected, that would indicate maybe more treatment is necessary. But if their antibodies tended to be maybe drifting down a little bit, I would never just use a report to make treatment decisions, I would interface the report with the patient's clinical presentation, but these reports are really helpful when the patient sees it on paper. They have a better understanding of what it is that may be causing them to feel unwell. So the take homes, there's a large number of Borrelia species. I think you just saw that. A quick turnaround of 7 days. You can do a serum and EDTA tube or 4 dried blood spots, which makes it easy to send the patient a kit at home. 4 dried blood spots is probably able to be accomplished by most, but patients can also take that to like their local doctor or if they have a nurse in their family and get the sample collected fairly easily, which is nice, especially now with being harder to travel or get around. So I've sent these kits to patients several hours from my office and had them do the kit there and send it in. And it's so nice to have those results come straight to me after that. The pricing is listed here. I showed you the whole page with the whole panel. The whole panel itself is $750, which is so cost effective for all of that data. If you break the columns out separately, each one is individually $199. So you can see that one of the best things about using this particular lab is they have a heart for helping patients get testing and getting comprehensive testing without charging an extraordinary amount, which we all know in clinical practice is one of our biggest challenges. So you can order individual follow-ups or the whole panel, or pick and choose based on clinical picture or your own personal preference. This is the clinical validation data, and I won't go into individual specific detail for each of these sample types, but if you look at the bottom, using the CDC criteria for sensitivity and specificity, you can compare those in the 3rd and 4th columns to the alternative criteria sensitivity, which I will say, basically the lab is using a criteria that's similar to CDC criteria, but they have gotten a little more specific in validating their data, where they'll use a borderline or positive result, and they're looking for the same critical important antigens. So like the VLSE1 or the C6 peptide, those are used in the CDC criteria. They're also used in the Vibrant Wellness criteria for establishing a positive or a negative. What makes the biggest difference is the number of other positives that are listed under IgM. They still use 2 out of 3 borderline or positive. For the IgG, they'll use 2 out of 10 instead of 5 out of 10. So I'll show you that in a minute when we get to the patient case. So here's the patient case. I saw this patient in my clinic a couple of weeks ago, and he was a good candidate for having this testing done. He's 46. He's an executive type salesman. He presented to the clinic and said he didn't feel well and was wondering if his blood pressure medication or his reflux medication might be the cause. And these are his medications: lisinopril, hydrochlorothiazide, and Nexium. It's kind of interesting. He has actually been on lisinopril since he was in his 20s, and hydrochlorothiazide was added about 10 years ago. He's been on Nexium for about 15 years. So none of these were new, but he was just starting to feel more and more unwell. When we went through a list of his current symptoms, has a lot of inflammatory symptoms, a lot of pain, arthritic complaints. He said he had to stop running, digestive issues. In addition to the reflux, you also have intermittent diarrhea. It's been scoped multiple times. He's had multiple tick bites in his past, but he did not remember having an EM rash or an acute illness following a tick bite. He had multiple cardiac workups for substernal chest pain, all of which were negative. He complained of rib soreness, rib pain, and feeling short of breath when he tried to exercise. And if you saw him, he looked like a fairly average guy. He didn't, look particularly ill, but when we started talking, he was like, I have a lot of symptoms. And I think he just kind of learned to live with them. And, you know, was also taking pretty frequent ibuprofen and Tylenol and having alcohol in the evenings that would help him go to sleep and things like that. I know those are the things I noticed quite often in my practice for someone that's still working. He also had sleep apnea and said he was using a CPAP every night and he felt like it helped. And he suffered with year-round allergies. I did do a Horowitz score on him and he scored 56, which put him at a high likelihood of having a tick-borne disease. I like to get an exposure history. So I asked him where had he lived, where had he traveled, and he had lived along the Eastern Seaboard a couple of different times as a child, including Rhode Island and in Virginia. He's also lived for several years in California. He also had traveled quite often to Europe, Mexico, and Brazil. This was the beginnings of his physical. His blood pressure was poorly controlled. His weight and height are here. His BMI, I believe, is 28. I put his pertinent positives on physical here too. He just looked like someone with moderate to severe upper respiratory allergies. And he had the cortisol belly pattern on exam, kind of the stress pattern with a protuberant abdomen, but not really any tenderness. And then a few scattered bruises and excoriations, but no rashes. This was the summary page. The lab does a nice summary at the top and then a detailed report to follow. So it's several pages long. So it gives lots of good information for what we're finding. He did test positive IgG for all of these different pathogens. As you can see, Lyme disease, tick-borne relapsing fever, Babesia, rickettsial disease, Coxsackie virus, Toxoplasma, and then a couple of viral herpes viruses, as well as Streptococcus A. And so, as I mentioned earlier, when I see a patient, I never just look at the lab, no matter what lab I'm looking at. I always try to look at the lab and consider it in the context of the patient's clinical presentation. And so I wanted to talk a little bit about him from the perspective of these results. Just looking at Lyme disease and thinking about the symptoms, I think those of us who treat patients with tick-borne diseases know there's pretty frequent arthritis, neck pain, back pain, systemic inflammation is common. Same thing with tick-borne relapsing fever. A lot of patients with tick-borne relapsing fever will have a dry cough, which he has allergies. So I didn't specifically ask him if he had a dry cough, but he has definitely some upper respiratory symptoms there. For Babesia, the symptom that he had that could point to that was some shortness of breath, although there's a lot of other causes. Nonetheless, he's definitely been in some places where he could have been easily exposed. Rickettsial diseases are interesting. The later complications of rickettsial diseases are things like vasculitis, neurologic symptoms, peripheral circulatory problems. And on physical exam, he didn't really have those, although he definitely has longstanding, hard to control high blood pressure. And I'm not relating that per se, but it definitely just is something to keep in mind. For Coxsackie virus, most of us just think of that as hand, foot, and mouth disease. But since he did have some IgG antibodies still circulating at his age, I have read sometimes people will get a chronic inflammatory myopathy that's related to Coxsackie and also other certain diseases, although he certainly didn't have a severe presentation of that. The other interesting finding here is the toxoplasma. You know, I go back in my training, you know, that was the one we always told pregnant women, don't clean out the cat box, because if you get toxoplasmosis while you're pregnant, it will harm the fetus. And about 20 to 40% of people in the United States will probably test positive for exposure to it. And most people will be asymptomatic. But what was really interesting, you know, he does not have cats. I did also ask him that, and hasn't been around a lot of potential exposure with that. But people who have been exposed and are symptomatic will have muscle aches and sore throats, sometimes an enlarged spleen or liver, and mild diarrhea. And the interesting thing also is the lab director had told us to me recently that in Brazil, they have a very high rate of toxoplasmosis. And he's traveled there several times for his work. So I thought that was interesting. 50 to 80% of women of childbearing age in Brazil have antibodies to toxoplasmosis. So it's from eating the cyst form of the parasite. So it's just interesting. I didn't feel like he was really clinically symptomatic for it, but it was an interesting finding on his lab. And sometimes when I look at these labs, I wonder if it's not a stacking of so many exposures as much as it is a singular pathogen that we need to think about. The other things on the list, the herpes simplex virus and the HHV6, both of those I see frequently positive. And even though they're so frequently positive, I still have a little concern in the back of my mind for them. There's some more international data that show that patients with dementia, a lot of them will have stain positive herpes simplex virus in the brain, as well as HHV6. So some of the postmortem Alzheimer's studies relate that potentially these herpes viruses are dormant, maybe intermittently reactivating. And even one study out of Taiwan shows that patients who are treated with antivirals seem to lower their risk. These are those patients that maybe have chronic recurring herpetic outbreaks, and sometimes we prophylax them or we treat them, with alternative methods, but sometimes they just ignore it and continue to suffer with intermittent, even just cold sores, fever blisters, and things like that. The other thing is just relating these herpes viruses to chronic fatiguing. We see a lot of positives in the patients who meet criteria for chronic fatigue syndrome or complain of a lot of chronic fatigue symptoms. And then lastly, the strep A was kind of interesting. We usually think of that one in kids with tonsillitis or impetigo. Some of the more serious diseases, there are positives. It's kind of interesting. I know there are some post-infectious immune disorders that come with frequent recurring strep in exposures. And I don't know if that is really clinically important for this particular patient, but it's interesting to see it on the lab. And he does have, some chronic sore throat issues that we might want to explore in a little bit more depth next time we see him for his follow-up visit. The other thing I wanted to quickly cover was whether I provoke or don't provoke in these particular tests. And for those of you who may not know what that means, there is some conversation out there in patients treating or in patients being treated with tick-borne disease that maybe we get a few more positives if we have the patient either do something to provoke releasing more of the particular pathogen into the bloodstream or into the renal system before the test sample is collected. And the way I've done that in the past, I've kind of played with that clinically, is have the person either get like a 1 hour deep tissue massage or vigorously exercise if they didn't want to do the massage, or maybe use a rebounder. Some people will give things orally, such as glutathione, or even combinations of those to try to provoke. What I have found is when I ask patients to do something to provoke the showing up of these pathogens, a lot of times they go home and they don't do the test. It's an extra step. They already don't feel well. They're distracted. They either don't want to schedule and go pay for a massage, or are they're in too much pain or too tired to go do the exercise. And so they just put it off. So I have found in just using this particular testing that I'm describing tonight that I pick up a lot of positives without doing the provocation. I'm not saying it's right or wrong. It's just, maybe in a patient that we get a negative on and we feel really strongly that there's something not showing up, that might be for me, that would be the logical time to ask the patient to perhaps go do something to provoke. But I don't think it's required. I think this testing is so good that you're going to most likely pick up some pathogens that are going to match the patient clinically. That's been my observation of using this particular testing for the last several months. So this is his data in a little more depth. You can see that he meets the alternative Lyme criteria, but not the CDC criteria. If he had had a couple more positives in the IgG column, he would have hit the CDC criteria as well. This was for the Borrelia bavariensis, which is a European strain of Borrelia. It's kind of interesting. I don't know if it's clinically relevant, and honestly, he would be fairly well covered if treated for all of these pathogens, probably to be covered for that as well. But it is interesting that he has spent some time in Europe. The Hermsii is one of the most common species that we look at for tick-borne relapsing fever. And he was definitely positive for that one. He also, you can see here, had a couple different positives for Babesia, the Rickettsia, the Coxsackie, the Toxoplasma. Hopefully the Toxoplasma was just an immunity. The HSV1, the HHV6, and the Strep A are all on this slide. These are just reminders that every tick bite is an opportunity for tick-borne microbes to infect and colonize the host. And these things can just sit there and hang out and wait until the person is in a vulnerable place, and then cause recurring inflammatory symptoms that the patient has a hard time explaining. I think if you're on this webinar, you are probably looking for ways that maybe you can look at a patient differently and do a workup that might reveal some root cause that's treatable, that might result in a resolution of some of those symptoms and better quality of life for that particular patient. Just as a reminder, the advantages of using this test is that it's a single run, it saves time, it reduces the cost of labor and instrumentation. It eliminates a lot of the need for manual handling and subjective interpretation because it's fully automated. And all of those efficiencies save money for the patient, which is probably one of the best parts, aside from the fact that you're getting good quality data. So we will stop there with the presentation, and now we will take some questions.
Thanks so much, Dr. Offutt. Let's see. I will give everyone just a second. If you do have a question, feel free to type that in to either the chat or the Q&A, and we will get that answered. I do see that somebody did ask about the recording. Yes, in the registration link, it does say that the recording will be sent out. And we also always post our webinars in our educational portal as well. So once you log into your provider account, you can view all of our past recordings. So that should be available if anybody else had that question. Let's see. So Lori has a question. Will you discuss the difference between the Western blot and the tick-borne panel?
So this technology is using the immunochip or the microchip technology, which is basically those three ways that they find the antigen, the whole cell sonicate, the peptide, the recombinant protein, or the peptide analysis. They are using that in the lab in a well, where it will detect the presence of, basically they're looking for IgG, IgM, or PCR. And so it's still very much in line with the same type of Western blot technology. It's just more modern. And it can be done with a smaller sample size.
Great. I actually have an email. I have a couple of email questions from a provider. So Dan had actually asked, have studies been done showing whether or not the testing predicts response to antiborrelial treatment before and after treatment, specifically to show if it can identify those who will get better if treated from those who will not?
That's a very good question. And actually, presently, one of the big pushes in ILADS is to do a big data collection, because so many different practitioners out there who are treating these patients use a huge variety of strategies for treating them. And we would all love to have more data that shows what works better and what doesn't work better. The MyLyme data bank is I believe, the biggest data bank in the United States, where patients put in information about their responses to therapies. I'm not aware, as far as this particular lab, that they would have that kind of data, because they're more in the testing side, not so much in the treatment response side. But I love that question. And I think all of us that treat patients are always looking for more consistent, standardized ways to collect information on who responds to what treatments. So I think using tests like this and having more information and feeling a little more confident in the results is only going to help as we look for more solid outcome numbers over time. If the big data can never really come to fruition, I'm hoping it will.
Great. Let's see. Kyle asked, do you retest? And if so, how long after?
So the way I usually approach it is, most of my patients, I treat them for a minimum of 6 months, and oftentimes longer. I mean, that's the minimum. And then I'm always looking at their clinical response. If someone is 100% better than when we started and they did the therapy, I don't always require them to retest, because a lot of times if they're clinically better, I feel confident that they're better without having them spend the money to do extra testing. However, a lot of patients want to see it. They want to see, did it work? What did it do? I want to see my numbers. So I'll share that decision-making with the patient. And if the patient really wants to test, the nice thing about this test, if they are not positive in all 4 columns, you could just do the retest in the column where they had a positive. So that's kind of nice, the way you can manipulate your order based on each patient. And if I do test, I usually don't test immediately following therapy. I usually wait at least 4 to 6 weeks. And that just lets us have time for the treatment to kind of be out of their system, and for them to kind of be back to a baseline where I feel like I would be looking at them without any therapies on board.
Great. Thank you. Let's see. It looks like we have some Q&A questions here too. Let's see. So Doug asked, how do we determine if the antibody testing is showing past infection versus active infection?
That's what I was talking about with a clinical picture. So the testing helps to look for exposure. And honestly, this particular patient's test was unusual in having all IgG. A lot of the test results I get back will have IgMs also. Sometimes they'll have just IgM. Sometimes they'll have IgG and IgM and PCR. I always take those results and look at the patient and what's going on with the patient. If the patient has the symptoms of a particular pathogen, I will interpret that myself to mean that that's what we need to target. It's also a lot about, like, from the integrative medicine side of things, it's also about helping the patient have a better immune system, to a stronger constitution. The whole terrain theory, if you're stronger and healthier, you're going to get well more quickly and in a more lasting way than if you're eating terribly and getting very little sleep and staying stressed all the time. So I always just use this data to help me make decisions based a lot more honestly on clinical presentation. And if the patient's got the symptoms and they've got the positive, I will use that to develop a treatment plan for that person.
Great, thank you. Okay, so Patricia asked, positives in healthy people who are asymptomatic, are you testing out of curiosity or have you seen false positives?
I almost never test an asymptomatic person because most of my patients that come here are fairly ill. I think the only case I can recall would be a mom who had been ill for a long time, brought her daughter in after one headache, and she wanted her tested. And I kind of tried to talk her out of it because honestly, I don't think it's appropriate to treat someone who's had one symptom or no symptoms. So to me, it's a waste of resources and it only stirs up fear and angst to do tests on someone who doesn't have symptoms. So I usually try to talk them out of it. Although I don't see a lot of patients who feel good and are asymptomatic.
Great, awesome. Let's see. Also in the Q&A, Valerie asked, can you talk about the frequency of Powassan virus you've seen and the clinical picture? So this is a good question because I think this is something that we really haven't been able to cover until we've added those additional infections to the test.
Yeah, that's a great question. And at iLads every year that's spoken of, like different presenters will talk about it. Until this test, I haven't been able to test for it. So, and this is so new that I haven't sent several of these panels off to the lab. So I haven't seen a positive test for that. That would, be something that for which I was clinically suspicious. I know most of the time there are so many other pathogens to consider that particular one doesn't pop into my mental space of thinking as far as my differential diagnosis. But now that it's on this panel, that will be something really interesting to watch and follow. I just haven't really had that data before, so I really can't speak to the frequency or the prevalence, especially where I am.
That would probably be a good topic to follow up and touch back on after we have, 6 months or so worth of data from people running that panel. That would be interesting to see.
It would be.
Great. Okay. Let's see. A couple more questions. Lori asked, if a patient has a positive on 2 bands of Western blot, we treat the patient with doxy for 30 days. Then when do you recommend we order the tick-borne or the Lyme Plus? So basically, if they're treating the patient first with a positive from Western blot.
So if I understand correctly, so we're treating an acute case, like a patient was tick bitten and they're going to get doxy for 30 days. And then when to test after that? Do you think I'm interpreting that? Mm-hmm. So it depends on the patient, because if the patient has any symptoms, like they need to be treated for longer than 30 days. If they just were maybe tick bitten and they're being covered for that, like a tick bite without symptoms, would be different than a patient who was tick bitten and developed symptoms. If they develop symptoms, I probably would order this test earlier than later, just to know what all the exposures were, especially because you're going to get that PCR data. So it depends on, I would need a little bit more information about the patient, but just say a patient is asymptomatic tick bitten and you're covering with doxy for 30 days and then you stop. If the patient has no symptoms, I think you could wait and, have a low threshold for testing, but wait and see how the patient does, especially if the patient's healthy and active and strong and has that good immune system. Now, if you have a patient who's more weak and vulnerable and frail, who has some symptoms, I probably wouldn't even wait 30 days. I might start the therapy, wait a couple of weeks, and then send off some tests.
Okay, great. Here's a question about testing and treatment from Kyle. Do you ever have testing numbers go up after you treat? how do you handle that? Or for instance, a new test positive that wasn't there the first time?
That does happen sometimes. And that's kind of the interesting part of thinking about the provocation. I think sometimes some different pathogens are more quiet, and other times they're more active. So I have had patients that I was just clinically convinced had Bartonella, for instance. Maybe they even had like the typical rash that patients can get with that disease, or a lot of the clinical symptoms. And then I get their test back and it's negative, but they test positive for, say, Lyme disease. So I'll usually, there's so much overlap, and we know that these infections don't occur singularly. They usually occur in cluster groups. That's why they call a lot of the secondary infections co-infections. They're honestly not really a secondary infection. They're an infection along with the Lyme disease. So a lot of times if it's positive and they have symptoms of Lyme as well, I would treat the Lyme, but I still have that clinical suspicion in my mind of the Bartonella. And if they have other symptoms, all of these diseases have clinical presentations, and even Lyme disease itself is a clinical diagnosis. The lab just really helps us confirm what we're clinically suspicious of. So I have retested or tried a different test and found it to be positive in a patient that did not test positive initially. I usually don't see, like, I don't do a lot of follow-up testing quickly. So when I see someone, say I treat them for a year and they're better, and I wait wait a month or 6 weeks, and then we have a check-in. Unless they're really having some residual symptom, I don't always do a follow-up test unless they just want one. And then when I do, sometimes I will see that something that wasn't there on the first test will be present. And if they have symptoms that match the test, I'll treat it.
Great. Perfect. Let's see. We have a question here from Valerie on if a patient has mold toxicity in addition to chronic infections, like Lyme or co-infections, would you treat the mold first or concurrently?
Depends on the patient. I know I keep saying that, but it really does. So if the patient, I've had this happen several times. This is just logistics. The patients here, Vibrant America has a great mold mycotoxin test I use all the time. Also, I didn't talk about it, but I use it frequently alongside these other tests. So say I want to be very comprehensive. I send off a tick-borne disease panel and a mycotoxin test. And when they come back, I almost always have some positive mycotoxins. So if it looks like, after exploring that more with the patient, that they're living in a home where they're being frequently exposed to mold, I know they're not going to get better until they get into a new environment. I will have them be working on that while I'm treating their Lyme disease, and maybe giving them a couple of things to help with the mold. I call myself a sequential treater, not a stacking treater, because if you stack all these therapies together, it's just overwhelms people. I mean, I don't have any patients really that can do mold treatment and Lyme treatment and Bartonella treatment and herpes virus treatment, like all together, without being overwhelmed with steps and expense and just the complexity of it. So I will kind of pick the symptoms that stand out the most as maybe the most problematic for the patient and try to address those first. Whichever pathogen or exposure matches more closely with that, that's what I'll go after first. And I always have that mold thought in the background of every patient. I like to get those tests right alongside these tick-borne panels and have them be investigating that further while we start their treatment. So, and then we do overlap them a little bit. It's not that we stop one and start the other. I'll be phasing one on at one office. I phase another one on. But I don't always treat mold first, and I don't always treat tick-borne disease first. I treat the patient depending on their story and their situation. So it may be different from each patient to each patient.
Great. I think we covered all the questions. I'm just scrolling really fast. Oh, one more. Let's see. So Carl asked, have you found methylation issues with Lyme not related to the MTHFR defect?
Yes. Well, it's so interesting how many more patients are getting a more comprehensive genetic evaluation. In the patients who have those methylation challenges, definitely just are more prone to inflammatory diseases and neuropsychiatric presentations. And a lot of them come in, they're on a lot of medications, and a lot of the medications are causing more problems with methylation. So we look at that too. It's very complicated, but I also know that addressing that for some people is what gets them well. So there's a couple of other doctors in my area that's almost like their specialty, and sometimes we'll kind of co-treat. They'll dive in all the way on looking at all their different methylation issues, and I'll be treating, you know, the pathogen side and or some of the other immunologic side. And it does seem like that's what gets patients fully well sometimes.
Great. That's actually a really interesting question. Let's see. I think we hit all the questions. Well, actually, I think I have one more email question. Let me just run through this. Okay, actually, nope, it was about provocation, which you covered. So I think we actually hit everything very quickly. I just want to thank you, Dr. Offutt, for your time tonight. Thanks for all the information that you shared, your expertise. So as I mentioned before, the recording will be up in the portal. And also if you've registered for the webinar, you get an automated email that goes out with the recording link too. So there's a couple of different ways that you can access it. And we will try to make the slides available as well as something that you can download. Let's see. Svetlana, the publication that was mentioned actually went out in an email from the marketing department, myself, today to all of our accounts, as well as that is something that's going to be available to download as a PDF since it's a free full text study. You'll be able to get that in the portal. But if you, for some reason, cannot find it, if you know who your local territory rep is, they will probably also have a copy of it that they can forward, or we can send you the link if for some reason you're not able to find it. So I want to just thank everyone tonight. So Dr. Offutt, thank you so much again. We'd love to have you back in the future, maybe once we do get some more cases to sort of look at trends and patterns on some of those lesser detected infections that, that as we've seen tonight can pop up right next to tick-borne diseases.
Thank you, Sarah. I want to encourage anyone listening, if you have questions about your patient's clinical questions, I'm more than happy to help. You can reach me. You saw, I think my name was on one of the first screens, Amy Offutt. I'm in Texas. If you go to my website and just inquire there, like I'm happy to help if there's any specific patient data or patient question. My dream is for more doctors to treat these patients so they get treated earlier and more fully, and just make a difference in like so many of the chronic suffering patients' lives. Thanks for having me.
Yeah, absolutely. Thanks. Have a great night, everyone. And we'll see you back again for another webinar next month.